we have one lecture in this test block, this 2-week period, one lecture in the next 2-week period, and then 4 lectures in the last period related to pathophysiology. We have to teach you pathophysiology. It's an accreditation requirement. So the way we view pathophysiology is to provide you information over certain disease processes and mechanisms of pathology as the year goes on. It's not a full pathophysiology course. It's a series of select pathophysiology lectures based on certain things you need to know. And today's lecture is on inflammation. This is a basic process, as are the other 5 lectures in pathophysiology, this course, Intro to Human Form. These are all basic processes that you need to understand as you get into the clinical courses, okay? Inflammation is going to be part of every clinical course that you take for the rest of the year. So we're just going to go over some basics of inflammation today for a little while, okay? Inflammation is characterized in medical terminology as itis. Itis, inflammation of, which is preceded by the system. Appendicitis would be inflammation of the appendix and so on. Okay. So the first slide here just gives you some overriding principles of inflammation. First of all, when you describe inflammation, you typically describe it as acute or chronic. Asthma would be a type of chronic inflammation. Acute inflammation occurs because of an insult, an immediate insult, and your response to that insult can take anywhere from a short period of minutes to a few days. As an example of one that would inflammation that would happen in a few days is the contact dermatitis associated with Rhus dermatitis. Rhus, R-H-U-S, poison ivy. Rhus dermatitis is poison ivy. So you know that when you get poison ivy, you don't start breaking out for 24 hours or so on. But if you get a bee sting, for example, your inflammatory response is immediate, so minutes to days. And it says here it can last hours to days. In the case of Rhus dermatitis, that can last 10 days to 2 weeks. Now, here's an important point here. Inflammation is characterized by exudation, and we're going to define that word exudation here in a little bit, but that's an important word. Exudation of fluid and junk, plasma proteins, cellular elements, debris, all sorts of things. That defines an exudate. Now, you see where it says mostly segs? At the bottom I've added there the definition of a seg. A seg is short for a segmented neutrophil. A neutrophil, or a seg, is also called a PMN, or a polymorphonuclear cell. Basically, it's a cell that it focuses on attacking bacteria and responds to inflammation very quickly. I'll go into more detail about it later on, but that's, when I say the word seg, sometimes I may say PMN, sometimes I may say poly, sometimes I may say neutrophil. Understand it's all the same thing. They're one of the 5 cell types, white blood cell types, you have in your circulation. And it's the most abundant cell type adults have in their circulation. Okay. Now, when the offending or the noxious element is over, then acute inflammation begins the process of repair. And you see repair in the bottom part there may happen because of regeneration of tissue. And an example there of that would be if, last night, I want to show you something. I was watching HBO. There was a show called Shameless. Anybody ever heard of that show?
I skipped over it last night as I was looking for my policy.
And one of the actresses, I took a picture of it. She looks exactly like you.
I get that a lot, actually.
Doesn't she? I mean, she looks exactly like you. That's Nikki Rubin.
Skip out on the camera.
Oh, okay. So I took the picture. I couldn't wait. I forgot that till you walked in. I said, I remember the picture. For regeneration of tissue, like a laceration of the skin, a bee sting, the repair of that, by 2 or 3 weeks, you have no evidence that there was a bee sting there. You can even take something like laceration of the liver or removal of the liver. The liver is one of really the only viscous you have that actually can regenerate. So you can remove part of the liver, which produces a huge inflammatory response to the liver, but it will regenerate over time. May occur through scarring, you know that on the skin. Scarring also happens following a myocardial infarction. You have an ischemic area of the heart that dies, and it scars, and you can see that where the myocardial infarction was on autopsy specimen by a whitish appearing area, and it's the whitish coloration has to do with the overall color of collagen, which is the predominant repair matrix protein in your body. Okay? All right, so going back up to the top there, the cardinal signs of inflammation. And these cardinal signs were realized hundreds and hundreds of years ago as rubor, which means redness, calor, which means heat, dolor, which means pain, tumor, which means swelling, and Virchow in the 1800s added another one to this, which would be loss of function. All right, so those are the cardinal things, cardinal signs of inflammation. Now, I mentioned earlier that exudate equaled inflammation. There's another type of fluid that you're going to run into. It's called a transudate. A transudate is more related with, and I'll give you 3 examples there, renal failure, congestive heart failure, and hypoalbuminemia. Transudate is essentially a shift of fluid from the intravascular space into the extravascular space without all of the proteins and cellular elements. It's just fluid. An example of that would be when you get a sunburn or you've had a heat burn and you get a blister, you know that the juice that's in there is kind of yellowish, but it's not pus. It's thin, yellowish. That is an example of a transudate. Transudates and exudates are also compared in this chart here between the color being yellowishy in transudate, and on the exudate, think of it more as pus. And there are a whole bunch of differences between the two. You can see down there that the cell count and the enzyme content, which represents protein, is low in the terms of transudate, is high on exudate. Just think of a thick, creamy, white pus versus a apple juice. That way you can sort of know which one's which if you were asked a question. In the bottom panel there, you see that inflammation is not present in transudates. It's just a shift of fluid from the intravascular space to the extravascular space versus transudates. You still get the fluid shift, but accompanying the shift, you get proteins and cells that go with it. All right. In the next test block, the Pathophys lecture is body fluids, and we'll talk a lot more about the fluid dynamics within your body at that time. All right. Acute inflammation. These are the different elements of acute inflammation. And you can look at these, and if you go back and try to correlate them with the cardinal signs, they make sense. When you've had your own inflammatory issues. First of all, you get a huge vascular response. Initially, it's vasoconstriction to prevent bleeding at the site, for example, or exsanguination, which is immediately followed by vasodilation. If you vasodilate something, you're going to get more blood into the area. More blood equals more reddish. More blood is also warm, so you're going to get more heat to the area. Okay? With the vasodilation, you get permeability changes in the vascular, primarily on the venous side. So fluid and cellular elements can leak out of the venules, causing the tumor or the swelling. All right? Because the vessel dilates, now you start getting sluggish flow through the vessel. Remember, we talked the other day about decreasing the size of a vessel, it exponentially increases the pressure in that vessel. I think I was talking to somebody at a cadaver tank about that. Conversely, if you dilate the vessel, the pressure inside the vessel goes down exponentially. And that's what happens here. The pressure goes down. And unfortunately, blood doesn't like to be static. When it starts getting sluggish, it starts to clot. And the red cells even start to pack up. That's the hemostasis or hemoconcentration as part of the process. If you look over there on this diagram here, one of the interesting things about this is you get fibrous tissue fibrin develop within the venules. The fibrin causes the red cells to stack up on each other. The red cells, look like little donuts, and you get strings of them like that. That's called the rouleau phenomenon. When red cells start stacking up, it's a sign of stasis. It happens in several different diseases as well. All right. Adhesion occurs between cellular elements and the walls of the blood vessel. And then you get migration of cells from inside the vessel to outside. Neutrophils would be one of them. Another one that I'll mention here in a little bit would be monocytes. Monocytes is another type of white blood cell. And when it's in your circulation, it's called a monocyte. And it's essentially an inactive cell. When an inflammatory process occurs, that monocyte migrates out of the vessel into the extracellular space and develops into a macrophage, which eats stuff. Debris, bacteria, dirt, whatever. So you get migration of cells from the intravascular space to the extravascular space. The migration of cells there, they start releasing agents that attract more cells. So it's a self-propagating process. That's the chemotaxis. Chemotaxis is the migration of cells along a chemical gradient. So you have chemical messengers that are released by these cells that have migrated. They produce more cells. The presence of more and more cells along with some of these chemical agents, produces pain. Some of the chemical agents actually stimulate afferents to signal pain. Aggregation and phagocytosis are self-explanatory. The last thing here under phagocytosis, where it says NO, that's nitric oxide. Nitric oxide is essentially a gas that's released by certain cells and the endothelium. It is toxic. It produces vasodilation, which is going to propagate the process more. Interesting thing about nitric oxide, it's essentially stimulating the production of nitric oxide is what Viagra does. By vasodilation, you get erection. So that's how those erectile dysfunction drugs, Cialis, Viagra, they all work by messing with nitric oxide. Any questions about any of this? All right. So this explanation here essentially says what I just said. So if you didn't catch what I said, there it is. The two panels here show you what happens in inflammation, in acute inflammation. The one on your right is a histology of a normal lung tissue. These large spaces are the alveolar sacs, lined with cells, different types of cells here. That's where gas exchange occurs across that thin membrane of cells. The vessels of the lungs are within the corners of these spaces, so that you see that gas exchanges has to cross a few membranes, but nonetheless they're very thin. But on the other side here, this is what happens when an inflammatory response happens. You lose the architecture of the alveoli. This would be an example of pneumonia, where you have an increase in blood flow. The pinkish red things are RBCs. You have a lot of RBCs in the area from these swollen capillaries. You also have a lot of gunk that's present in the alveoli. You can barely recognize the alveoli. You can see a few of them, or see the outline of a few of them, but they're usually filled with all sorts of junk here. This is what an infiltrate looks like in pneumonia. Okay. Obviously, gas exchange is not going to occur well here, and if you get a huge pneumonia, obviously it's easy to understand why you would have shortness of breath and trouble with your respiratory function. Okay. The stimuli for acute inflammation, there are tons of infective organisms of all species. It says receptors there. Most of these things come with receptors on their external surfaces, bacteria particularly, and viruses. Well, they all do. And these receptors, or these proteins, these external proteins, serve as points of initiation of the inflammatory response. Your body is able to recognize those receptors as foreign and activate the inflammatory response. That's why cancer is so hard to treat, because the cells, even though they're essentially foreign, they have the same receptors as the rest of your body. It's hard for you to identify and to kill cancers on a routine basis. Tissue damage, that's kind of obvious. Foreign bodies, splinters, whenever you suture somebody, you need to understand you're putting a foreign substance in the body. Any type of medical appliance is a foreign body that you're going to react to. Dirt, road rash, you're in the ER, you're going to run into a lot of road rash from people falling off bicycles, motorcycles, all sorts of stuff. And you got to clean that out. One time I had a patient who came in, the patient was, I don't know what the politically correct term is, mentally challenged. Anyway, they'd been in a fight with somebody else at the home, and the other person had bit this person on the forehead. And so the provider sutured them up without x-raying. Anytime somebody gets bitten, take an x-ray of it. Because what they failed to do was recognize that there was a piece of tooth left in the skin, and they sutured it up. It wound up as a foreign body site of infection and inflammation, and they came in with this pus-draining, sutured up wound here. So anytime there's a bite from an animal or a human, I would x-ray it just to be on the safe side. Do you have a question?
What piece was in it again?
Huh?
What piece was in the forehead?
The biter's tooth had broken off. And it was so when I looked at it, and that I learned that that's how the laceration got there in the first place, I x-rayed them and saw the fragmented tooth. One of the things here about just as you go through life, you have to be cautious about suturing up bites of any kind, because bites are typically dirty, especially those of humans. Komodo dragons and humans, worst mouth in the world, okay? Immune reactions, autoimmune disease, like rheumatoid arthritis is an inflammatory process, you know that. And allergies to drugs, and bee stings, and scorpion stings, all that sort of stuff. All right. Cellular elements involved in inflammation. The endothelium is the internal lining of the vasculature, the innermost lining of the vasculature. Ordinarily, in most places, it's the endothelial cells are connected, and stuff doesn't leak through the spaces between them. For stuff to get out of the vessels, it has to cross into and then back out of the endothelium. But in this type of process, what happens is they become leaky. They separate and allow, there are now gaps in the endothelium that stuff can easily pass through. SEGs we talked about. Lymphocytes is another type of white blood cells. There are several types of lymphocytes. B lymphocytes produce antibodies. They're instructed to produce antibodies when given a certain set of signals. There are T helper cells, that's the TH. T helper cells, what they do is they amplify the immune response. They amplify antibody production. T helper cells have a cell receptor on them called CD4. It's the CD4 cells that AIDS kills, the AIDS virus kills. So what happens in AIDS, why they get opportunistic infections, is they have a decrease in the cells that amplify the immune response. Everybody follow that? So that's why they get Gerevicious infections, the old pneumocystis carinii, Kaposi sarcoma, the coccidiomycosis, all the different opportunistic issues that occur in AIDS that eventually kills them are because they don't have enough T helper cells that can amplify the immune response. There's another type of T lymphocytes, it's called natural killer cells. These cells have a cell receptor called CD8. And what they do is they attack cells directly. They secrete a protein that's like a toilet paper roll. You know, a toilet paper roll, this protein, it gets inserted into other things like foreign cells like a graft or bacteria, and because it's like a toilet paper, the target starts leaking their gunk and they die. Do you know that they make toilet paper now without the roll?
Yeah.
I hate that stuff. My wife bought some of that stuff. Why? Why? I mean, that's green to just gone extreme. Another thing about green that really gets on my nerves is we have our blue recycle box down on the landing into the basement. So when I finish a Diet Pepsi, and I've got this aluminum can, and I'm going to throw it in the box, you know, from up here, I toss it into the box. I turn on the light to see the box, and then toss the can. I guarantee you, the electricity that was used to burn the light for me to throw it was worth more than the can. You guys see what I'm saying? It just irks me every morning to throw that can down there in the dark. I saved cans for 3 months last summer. I saved cans. I had a massive amount of cans. I took them to the recycler. I got $7.
That's probably your gas on the way there.
Hey, that buys another can.
No, I spent it in gas to get to the recycling, which is way on the south side on Western, which is like 30 miles from my house. I don't get it. You know 95% of all aluminum is recycled? That's pretty impressive. But it's not damn Diet Pepsi cans. Okay, monocytes. We talked about monocytes, macrophages. They eat things, right? Eosinophils are very active in the immune system for a couple of reasons. One is eosinophils, it's another white cell type, as are basophils. So those are the 5 white blood cells. Segs, lymphocytes, monocytes, eosinophils, and basophils. Eosinophils are allergy is real big with eosinophils. Allergy and parasitic worm infections. For some reason, if you get a roundworm infection, you have an increased number of eosinophils. They're the ones that have the enzymes within them to target, to try to combat the worm. The other thing is allergies, like seasonal allergies. You know how some people, you see them, especially little kids, they have that little drip of clear snot right there. I'm not talking about if you have a cold. I'm talking about, you know, the kids that get so like that, you know, there's actually when they have a crease on their nose and dark circles in their eyes, it's because of, you should think of severe seasonal allergies. Anyway, you know what I'm talking about, the little clear drop of stuff. If you were to take that clear drop and put it on a microscope slide and stain it, it would be a complete sheet of eosinophils. That's what that. If you want to touch some eosinophils, the next time you get that little drip, just touch it. Then you touch the eosinophils. Okay, it's a complete sheet of eosinophils. Basophils they're the least prevalent cell, white blood cell in the circulation. They are also, though, responsible for the immune response. They have a couple of substances in them, histamine and heparin. Heparin thins blood and will make you bleed. In other words, increases the leakiness of the circulation. And histamine, you know what histamine does. It increases mucus production, increases the vascularity. Obviously it does that because you constantly are taking antihistamines for your nasal congestion in Oklahoma. Basophils, a little thing in case you're on Jeopardy here, if you have an increase in basophils in your circulation, it's for one of two reasons. Either you have cancer of that white blood cell type, or you have SBE, subacute bacterial endocarditis. It's an inflammatory infectious process of the lining of the heart. SBE, or a type of leukemia. Elevated basophils. Nothing else makes them go up. Okay? Platelets, of course, are going to help produce some of that clotting, that stagnation. Mast cells are like basophils. They're not the same. They're derived from two different cell sources, but they have the same function. Mast cells contain, their granules contain heparin and histamine and other things as well. But they're very active in the allergic inflammatory response. Matter of fact, one of the treatments for allergic conjunctivitis, itchy eyes from allergies, or asthma, is a mast cell stabilizer. There's a drug that's a mast cell stabilizer. You try to prevent the mast cells from degranulating to initiate the allergic response. When I say allergic response, understand that is an inflammatory response. Right? Plasma cells are grown-up B lymphocytes. A B lymphocyte, you have a bunch of, the lymphocytes are the second most populous white blood cell in your circulation, by the way. Segs, then lymphocytes, eosinophils, basophils, and monophils, you only have, like 2%. Segs would be 60%, lymphocytes about 35%, and then the rest of them are the other three. Did you follow me there? I said that kind of fast.
Yeah.
You're good? Okay. Plasma cells, though, when a B cell is activated, it turns into a plasma cell. A plasma cell is a grown-up B cell, and it is one immune globulin producing monster. It just pours out IgG antibodies. You see a lot of plasma cells around your orifices. I mean, inside the mucosa of your orifices, where external things have access to you, like inside your mouth or inside your anus. That's where you'll see a lot of plasma cells in the tissues. They're extravascular. You do not find plasma cells in the vessels. Plasma cells, they mature in the extravascular space. B cells leave the vascular space and become plasma cells. And fibroblasts, because of the areas you see there. Fibroblasts are never in the vascular space. They're part of the connective tissue, extravascular space. Okay. Here are some of the chemical mediators. You don't need to memorize that thing on the right. I just put it there because I thought it was kind of interesting to show you the interrelationships of all of these things. You don't even need to read it. It's just a pretty slide. Over on the other side, though, we'll tell you what some of these mediators are. Histamine and heparin we talked about. Serotonin dilates blood vessels. So when serotonin is released, it's also abbreviated 5-HT. It dilates blood vessels. Cytokines, interferons, and then the bottom thing there, all those arachidonic acid metabolites, they're all chemotactic agents. And that's, just know it as that. They're all chemotactic agents.
Which ones?
The cytokines, including interferon, platelet activating factor, TNF, which is tumor necrosis factor, interleukins, and all of those, there are like 24 different types of interleukins. These are all proteins that are circulating in the vasculature. They get out or are released by cells and produce the chemotactic response. A couple of them there, bradykinin and substance P. Substance P is actually, we talked about the peripheral processes of somatic afferent neurons. The peripheral processes out here. They actually have it's a weird situation with them. They actually have in their receptor ends vesicles that under certain stimuli, the sensory nerve will release those vesicles. A couple of the substances in those vesicles substance P is probably the predominant one. Bradykinin is another one. So the afferent nerve is actually detecting the response and then releasing these substances which act as chemoattractants. That's kind of interesting, isn't it? Give an example of where that comes into play. Substance P and bradykinin are broken down by an enzyme called angiotensin converting enzyme. Angiotensin converting enzyme, which is part of another whole system that regulates blood pressure, but nonetheless, that's the same enzyme that breaks down those two substances when they've been released into the tissues. One of the treatments for treating high blood pressure is an ACE inhibitor. Angiotensin converting enzyme inhibitor. Now, if you take an ACE inhibitor, you inhibit that enzyme, which then is no longer able to break down those two substances. Those two substances eventually build up in your trachea and produce your body's response to their presence by cough. Cough is a response to an allergen, right? To inflammation is cough. When you get, right there, you got something going on today with the cough. You know, got an upper respiratory, you got inflammation. What do you do? Cough. Why do you cough? Because you got chemotactic agents in your mucosa that are stimulating the cough reflex. If you take an ACE inhibitor, you block it, go look up lisinopril. Lisinopril is an ACE inhibitor. The first side effect of lisinopril will be cough. It's a class effect. If you start coughing on lisinopril, you will cough on all of them. And not everybody coughs on an ACE inhibitor. Okay? All right. So down the road, when you get into pharmacology and you get out on your rotation, now you understand why people cough on an ACE inhibitor. People generally don't know that. Now you do. You're smart. Okay? Complement, yes.
What would you do to like stop it?
You have to stop it. You stop it today, and you will not cough tomorrow. It's an immediate response that immediately goes away when you quit taking it. It's truly impressive. And it is, if you start somebody on an ACE inhibitor, they'll be back in a couple of days saying, I can't get rid of this cough, and they have no reason for the cough. Know that it's the ACE inhibitor. Change them to another type of antihypertensive. Complement. Go ahead.
Since bradykinin can cause pain, like the pain of inflammation,
Yes.
do people who have the cough usually have like a lot of pain?
They do not. The pain is not involved here. It's not to that level. It's just cough. It's interesting. Complement. Does anybody not know what complement is? Anybody, has everybody heard of complement? The complement system. I'm going to give a slide later on that kind of defines it real quick. But understand that complement is another system, another defense mechanism you have in your circulation against all types of foreign elements. All right, we'll just leave it at that. Now, this is a busy slide. I don't want you to get hung up on this slide. What I want you to just appreciate here is that these chemical mediators arise from these sources that we've been over. And if you look over there on the right-hand side, the actions give you the cardinal problems with inflammation. They give you swelling, redness, heat, that sort of thing. You can pick those out in there. This is just for your reading pleasure. All right, don't go home and memorize this. Okay. There's nitric oxide. You see where it says vascular smooth muscle relaxation. Okay. A couple of them I want to point out though. One of them is prostaglandins. You see where it says that they're prostaglandins? Its action is to vasodilation, pain, and fever. Fever is the calor element. Aspirin and ibuprofen, they inhibit prostaglandin synthetase, decrease prostaglandins, therefore decrease your fever. So a lot of things you're going to learn in pharmacology are related to these mechanisms. You know, a lot of these drugs that you see on the TV that they're advertising now, the newest one I mentioned the other day was about psoriasis. You treat psoriasis with this drug. I think it's Humira. Is it Humira that they use to treat? Humira is, and Remicade, you know, who's the golfer?
Phil Mickelson.
Phil Mickelson has arthritis or something. I can't remember what he has. What does he have?
RA,
rheumatoid arthritis. You know, they're taking medications that are tumor necrosis factor inhibitors or interleukin inhibitors. That's what they're biological drugs. And I can tell you right now, you know, I'm old and I'm catching the very beginning of this. But I can tell you right now that most of the drugs that you're going to wind up treating diseases that you deal with are going to be related to jacking with some of these chemical mediators. Okay? You know, they always say in these commercials that, you know, one of the possible side effects of these drugs is tumors, cancer. Well, yeah, they put that in there because if you start blocking the agents that actually can recognize your own cancers that develop in you, then you're blocking that mechanism. That's interesting. Okay. Any questions about any of this? Any questions about why I'm putting this slide up there? Okay, I don't want you to go home and memorize this slide. All right. Same with this slide right here. Interleukin-1 is also another one that has a role in fever. But prostaglandin synthetase inhibition is how these antipyretics like ibuprofen and aspirin work. This slide right here tells you, sort of summarizes the cardinal symptoms on the left and provides you on the right the chemotactic agents responsible for it. Again, this slide, the previous two, don't memorize them. Okay. You see there a pain right there next to the bottom, bradykinin. Who asked that question? There you go. All right. Now, patterns of inflammation. This is what you do need to memorize. These are the different patterns of inflammation. Because when physicians and PAs come in here throughout the rest of the year, come in here and start talking to you about these different disease processes, they're going to be using these terms and using the processes that produce these types of issues. So wheal and flare we'll start with. This is allergy testing. It's an immediate superficial response. You see right there the little thing with the dime on it. That would be like a bee sting, where you have tumor, you have swelling there with rugor around it, the redness around it. It also has some heat to it because of the redness. It usually always comes with heat. Okay. Some people actually, their skin is so sensitive, you can take your fingernail and rub it on their skin, and they'll react to it. This person right here reacts to it quite remarkably. Most people, it'll just be a redness, you know, that you can see, but this is actually swelling. It's called dermatographism when that happens. So it's a normal process, it's a natural process. It's just a hypersensitivity to this type of insult. Over on the right-hand side, is your right-hand side the same as mine? Yeah. I guess it would have to be. That was really a stupid statement. Is allergy testing on this guy's back. You'll see that what they've done is they've injected allergens into the skin. It could be to cat dander. By the way, cats, why do they exist?
Thank you.
I know, really? You and I are connected here. Why do cats exist? But I have two of them. I have two of them at home. Well, I don't have my wife. Why?
I had read a book recently stating that that Satan, in the Bible it says Satan prowls around like a lion, and so the guy actually compared cats to Satan because
There you go.
they were the feline family.
Another reason to go to church on Sunday. Another reason. All right, so allergy testing, they've injected all these different allergens to see what this person is allergic to. They can do it on the back, they do it on the arm. So when you go to an allergist, this is one of the things they do to identify your allergens. Okay?
What prevents the allergic response from affecting the rest of your body? Like when you do just a will and flare, how is that not?
Diffusion. You know,
So superficial.
The process, like all inflammatory responses, the process is local. And then the further away you get from it, the less chemotactic agents you have, and so the less it impacts that area. In other examples, though, your body actually will try to wall off inflammation. And I'll talk about that later on.
What cellular element causes this?
Well, what's happening here is you're getting vasodilation. You're getting the elements within the vessel to go out, the release of histamine and heparin, like I described earlier. Well, all those chemical mediators are being released here. And the worse the inflammatory response, or worse the offender, the greater the inflammatory response. The more sensitive, if you've been sensitized to something, you can have the response that goes beyond local influence and will actually affect your entire body. Example of that would be anaphylaxis. A bee sting, which should be a local response, instead becomes systemic. You close off you get the inflammation of your larynx, it closes off and you die of asphyxiation.
So are there some people that go into anaphylaxis during a skin allergy test?
That is a side effect of allergy
Okay.
testing.
Gotcha.
That is always a potential side effect of allergy testing. Now what they do is they usually start with such low concentrations and will build up. Okay? They don't dump a high concentration in you to produce a systemic response. But you know, if you happen to be so sensitive to it, you could go into anaphylaxis.
I've got this done before, and I remember there was a few that they did that were controls, just to see if I would react to it.
Uh-huh.
Do you know what they give as the controls?
Yeah. So they used to do, when they would do a PPD, you've had the TB testing, you know, where they do a little wheel there. They inject allergen or antigen into your system. If you've been exposed to that antigen, you're going to produce an immune response against it. So what happens is you get a wheel, you know, calor, rubor, the whole thing. You get a enlarged area. That's your body reacting. That means you've been exposed to tuberculosis antigen. As a possibility, you have tuberculosis. You've been exposed to it. So what they used to do is they would put a PPD on one side and put a Candida on the other. Candida is yeast. Everybody in the world has been exposed to yeast. Everybody in the world has antibodies to yeast. So everybody will react to the Candida injection. The control, so that's a control, a positive control. If you don't react to it, that means you can't mount an immune response. So if you have a negative PPD, it's not valued, it's of no value. You can't mount an immune response. Okay, but they don't do that anymore. They don't do Candida testing anymore.
How is tuberculosis positive sometimes, but then when they do a chest x-ray it is negative?
You've still been exposed to the, well, you've most likely still been exposed to the bug. You were just able to clear it. You don't have TB. That's the follow-up. Take a chest x-ray. There's actually a blood test for tuberculosis now that they didn't used to have. But this is a screening mechanism that I can tell you from now on for the rest of your life, you will get one every year. Okay? Any questions? Other questions? All right. This is serous inflammation. Oh, by the way, what I'm doing is all of these things right here, I'm just going to go down each one, give you an example of each one of them here. Okay, serous inflammation. All right, so some definitions are over there on the right. Okay, very easy to understand. Effusions of joints. You know, if I get out there and like I did the half marathon, I walked the half marathon a few years ago with Professor Collins. Well, actually we all did, but she and I were the ones that walked towards the back. So 58-year-old joints going 13 miles, isn't it 13 miles? You know, will swell. The next day, my knees were swollen. That is a transudate. Okay, that was an overused transudate. You see there at the bottom, recall that an exudate results from inflammation, not a transudate. So this is an exudative serous inflammation. Okay? By definition. This serous inflammation is an exudate, not a transudate. Catarrhal inflammation is an inflammatory response involving mucous membranes, like your snotty nose, the conjunctivitis, with all the mattering of your eyes, you know, especially the little kids, they get this all the time in daycares. It's just an inflammation of the mucous membranes. On the autopsy specimen there, it's involved the trachea and has produced, in this example, asphyxiation because of swelling of the trachea, or the inflammatory response in the trachea.
So is it a transudate or exudate?
I'm sorry?
Is this a transudate or exudate?
All exudate. Everything I'm talking about here is an exudate. There's no transudates from now on out, because it's all inflammation. Basically.
On the slide before, it's like how you mentioned a sunburn, how it leaks fluid.
Superficial sunburn, yeah. This is a deeper thing. You see that stuff is, I mean, you can envision that's thick and gooey. It's actually, if you pull it out of there and put it between your fingers and elevate it like that, the proteins will hold it together. It'll be stringy. Okay. This is suppurative inflammation. Suppurative essentially is pus. The person, I guess that's a female, well, no, it's not the same person, because that's a guy on the top, and that's definitely not a guy on the bottom. There's a condition called hidradenitis suppurativa, which is the presence of frequent boils or furuncles, as we described the other day. These things become so frequent and massive. I mean, it's just, these people really suffer. And You see on the bottom slide there, some little pus droplets that are starting to, this thing's starting to drain in the inguinal region. The inguinal region, the axillary region, and around the anus, that's where these people suffer the most.
Does that condition flare up a lot with pregnant women?
Pregnant women. I've never heard it associated with that.
Okay.
Anybody know? I've never heard. This is actually a genetic issue, and it's, you ask people with this, and you know, my mom had the same thing, or my dad had the same thing, and it's a chronic thing, usually from teenage years on. It may flare with pregnancy. Everything flares with pregnancy.
Yeah.
But I don't know.
What's the difference between exudate and pus? Is there really?
They're the same thing, really, yeah. You know, an exudate, though, doesn't have to be pus. An exudate could be full of proteins and debris, but not infected. Pus is essentially an exudate that is infected. You can think of it that way. An exudate is there because of inflammation, but once that inflammation becomes infected, it's pus. If you were to sample that milky stuff coming out of these furuncles, it would be just a sheet of segs, a complete sheet of segs.
Can you tell by the color? Like, isn't pus more like greenish and
She said, can you tell by color? No, I don't think you really can. It really smells though. You might want to warn, if you're getting ready to incise and drain this thing, you might want to warn the patient that this is going to smell like, I don't know. I mean, I was going to say rotting flesh, but it's worse than that. You will be impressed when the first time you smell it, if you've never smelled it before. Go ahead.
I was just saying, it's awful. It smells like the whole ER.
It will smell up the whole, wherever you are, it will smell up the whole wherever. And it's the only thing that will eat Febreze. Febreze will eat everything else, but this eats Febreze. And so warn the patient that, you know, this is going to be an offensive odor, so be prepared. And if you have to throw up, as a lot of people will, just don't throw up on the patient. Turn and throw up on the floor. Am I kidding?
No.
No.
That's not an exaggeration at all.
Yeah, people will throw up when this smell hits them. Over here on the left-hand side there, this is called a paronychia. And what this is an inflammatory area. It can be suppurative. In other words, you can get pus collected underneath the nail there, or not the nail, but the skin. It's called the paronychia. Paronychium is the area of the body. Paronychia is an inflammatory, infected thing. I see them mostly when people, after mani-pedis, where they aggressively push back your cuticle and wind up getting it infected. So they'll come in with this blowed up tip of their finger right here. Hurts like all the bejesus. I mean, really hurts. And the way you get that, way you relieve the pain, is you take a number 11 scalpel blade, which is a sharp tip one, and you take it underneath the paronychium and you just incise it and drain that drop of pus out of there. Provides immediate relief. You might want to go ahead and anesthetize their finger because sticking a scalpel in a boil is not a fun thing to receive. Yes, ma'am.
So is it caused by the instrument they use is dirty, or
Yeah,
they just
yeah.
open it and then?
Yeah, it's probably the most common organisms is staph and strep, which you have all over your body. You probably infected yourself. It's just them doing the aggressive.
Making an opening for it to be.
Yeah, you just made an opening for the bugs. So,
What were the three areas You said inguinal, axillary, and what?
Around your anus, not the planet. Take a break, go pee.
I'll start
Next
off
type
with,
of inflammatory response here.
same thing.
Yeah, that's what mine started out.
We're dealing with a collection
Clouds.
of, we're dealing with a collection of pus. That's an abscess, as a furuncle, as we've seen. You can also have them though in body cavities. The example on the right side there is the gallbladder that's been opened, and it's just a bag of pus. On the lung tissue there, a collection of pus within the lung, or in the gallbladder, or in any organ, is called an empyema. It's an abscess of an organ, an empyema.
So are all abscesses considered furuncles and vice versa? Or
The
is there-
skin.
So furuncles are only skin and
Yeah.
abscesses are.
Yeah, so you consider furuncles of the skin, empyemas of the, well, you can call it empyemas like an abscess of an organ, but you can also call it just an abscess. That would be fine. Abscess is a global term. You can say this person has a lung abscess, but the correct term is an empyema. Remember, since it's pus, it's infected. So there are three terms you need to appreciate. Lymphadenitis in the upper left is a swelling of lymph nodes. You can see the lymph nodes in this woman in the inguinal region. I don't know what she has, but there are several disorders that will cause huge lymph nodes, particularly in the inguinal region, as a sexually transmitted disease. One of them is called lymphogranuloma inguinal. Lymphogranuloma inguinal. If you're ever sitting around this weekend and you want to Google that, just, hey, what is that? So, lymphogranuloma inguinal, caused by an organism of the Haemophilus species. Okay. If you happen to have it, raise your hand so we can all. Anybody has it? Okay. Lymphangitis, you see in the other two top panels there. When you hear about when somebody asks you if you have an infection, is there streaking? Are there red streaks? Have your mom ever asked you that, or somebody ever asked you, was it red streaking? You know, the red streaking has to do with the presence of SEGs, the infection, the spread of the infection within the lymphatic channels. The spread of the infection in lymphatic channels is lymphangitis. This is a more serious issue than just a plain cellulitis or a local inflammatory response. If you start getting infection spreading through your lymph system, you better be on some antibiotics. Also, the bottom panel to your left is lymphadenitis, swollen lymph nodes in the neck of that little kid. Lymphedema on the bottom right and in the bottom middle is blockage of the lymphatic channels. So the lymph cannot return to the venous system and you will swell. In the middle panel there, you can see that the lymph flow from the right leg is blocked. And you get this big, fat, swollen leg versus her left leg, or his left leg, which is normal. The same thing in the woman on the right, her right arm is swollen versus her left arm not. So one of the examples of that would be if she had a mastectomy and had the lymph nodes removed from the axillary region, it inhibits the or prevents the normal lymph drainage from the upper extremity, and they will have a unilateral, big swollen limb. You go to the mall this weekend and sit there, you will see somebody come by with a unilateral lymphedema.
What does a girl's cheek have? Like the neck?
What's that?
What does a girl's neck have? Is it?
It's just swollen lymph nodes right there. Right there.
So it's adenitis?
Adenitis, lymphadenitis.
Is there a way to bypass the lymphatic system and drain?
No, what you have to do is you have to treat it with compression stockings and elevation so that gravity will help you. Over at Good Shepherd, where you'll be spending some time, what's that guy's name over there? Glenn? I mean, horrendous lymphedema in both legs that was actually congenital because his mother had the same thing. But his legs were much worse than the woman in the middle. So it was very difficult. He was very difficult to treat.
Would you ultrasound that to just rule out DVT initially, like this in the leg, or?
The question is, would you ultrasound that to rule out DVT? A DVT lymphedema is immediate, is an acute response. Lymphedema is a prolonged response.
So you kind of get that from the HPI, just the history of.
You're going to get that from the history of the present illness. You're going to get it from the pathological processes that are going on with this person. Lymphedema is typically has a cause, and you're going to be able to find that or identify that pretty frequently. When we go through the body fluid lecture here in a couple of weeks, I spend a lot of time on the difference between lymphedema and non-lymphatic edema, being able to tell the two apart and the etiologies and stuff like that. So, I don't want to say too much about it today, other than to put it in the category of swelling. Yes, ma'am.
You said the bottom left was what?
The bottom left, that little girl there has lymphadenitis, swollen lymph nodes from, a sore throat, strep throat. Fibrinous inflammation is when you have actual adhesions that are produced by with two opposing surfaces. These adhesions are fibrinous in nature, the connective tissue fibrinous laid down by fibroblasts in response to the inflammatory response. The middle panel there is the pericardium. They removed they've opened up the pericardium. You're looking at the heart to the left of that arrow. You're looking at the pericardium on the right, and you see those strands connecting them. This type of inflammation you see frequently with pleural or within the pleura around the lungs, or the pericardium around the heart, or the peritoneum around the intestines. Matter of fact, the most common cause of bowel obstruction in a person who has had abdominal surgery are adhesions of fibrinous inflammation. Okay? Bread and butter pericarditis looks like buttered toast. That's the characteristic of fibrinous inflammation of the pericardium with these adhesions. Okay? Serosanguinous refers to two things: sero meaning the serum of the blood, and sanguinous meaning blood. So it's usually red. It's going to be red. It's red fluid, thick fluid. Serosanguinous inflammation of the appendix is what you see there, how it's red, swollen. Hyperemic is another way to describe that. Hyperemic. increased redness. Ulcerative inflammation, we kind of went over a little bit of this when we did the skin in anatomy. Ulcerative dermatitis, so the explanation is there on the right, the different stages, and basically it's just an interruption of the skin or a mucous membrane by abrading the surface. The surface breaks down, exposing deeper layers. The deeper you go, the worse the stage. Stage 4 up here, and stage 4 that I described the other day, is down to the bone.
Can this occur like in the mouth, like when they say you have an oral like ulcer?
There's a little thing, people get a little painful little shallow ulcers in the mouth. You get those? Everybody raise your hand if you get those. Almost everybody, who does not get them? Nobody, everybody's got them. It's not a sexually transmitted disease. It's not a virus. It's not a bacterium. It's not anything infectious. It's actually an antibody, an autoimmune response where you attack yourself. And it is a shallow ulcerative inflammation. It's called aphthous stomatitis. A-P-H-T-H-O-U-S. There may be another P or somewhere in there. Aphthous stomatitis. So if you're sitting on the toilet this weekend, you're going to Google lymphogranuloma inguinal and aphthous stomatitis. I get them, and they occur on the mostly the free margins and on the margins of the gingiva. I get them when I get a toothbrush. The bristles fray, and so as I brush my teeth, that fray kind of irritates a little spot, and then I'll get one. I'll get a little autoantibody response right there in your mouth.
What stage would it be?
What?
What stage would it be in?
It'd probably be a 2. It'd probably be a 2 because it's through the superficial layer. It's into the dermis.
I've heard you can get those from stress. Is that true?
Yeah, absolutely true. You all have different triggers for them. Stress is one. Some people it's eating spicy foods, hot foods. I mean, whatever your trigger is. Mine's an old toothbrush. So.
Is there a good way to always tell between serosanguinous inflammation and ulcerative inflammation?
If there's blood, it's serosanguinous. If it's red, sanguinous is in the picture. Okay. Any other questions about ulcerative inflammation? Here's a little bit more, some more examples. There's ulcerative gingivitis. You'll probably see that when you go over to do your dental rotation here in end of February. You know you're going to spend time at a dentist office, don't you?
What?
Yeah, you're going to learn some dentistry because dentistry is it's amazing how much pathology and disease comes from the oral cavity. And so we got a grant to spend some time with a dental hygienist and a dentist. Just a few hours, but you're going to see some pretty bad stuff. Any questions? Anybody here work for a dental hygienist? Dental assistant?
So I didn't work with one, but I would go volunteer at the OK Mom.
Yeah. Mission of Mercy.
I've seen quite a few.
Yeah, so you're going to get the chance to do that. It's interesting. Let's see. A healthy colon, there's ulcerative colitis. It's a chronic inflammatory condition of the colon. It's a premalignant condition. Can be a premalignant, well, it is premalignant. It's a problem affecting a lot of people. The other inflammatory bowel condition is called Crohn's disease, which most of the time, more often affects the small bowel, whereas ulcerative colitis affects the colon. A friend of mine has ulcerative colitis, and before they got on a biologic, they were like bleeding all the time. It's just a really bad thing. Duodenitis is an inflammatory process. Following the duodenum there, you see the red, swollen duodenal mucosa. Gangrenous inflammation here is just a loss of blood flow. It's rotting. Amputation is the only way to deal with this. In this bottom panel here about the necrotizing fasciitis, this little kid apparently was delivered into a toilet. E. coli is an enteric pathogen, or enteric bacteria, meaning that you have it in your colon normally. And this kid developed this fasciitis from E. coli, eventually died, but anyway, that's a necrotizing issue. It necrotizes, it's not flesh-eating as a description here, it necrotizes because the bug, the bacterium, produces toxic substances that cause the tissue to die. One area that you maybe remember or know about is toxic shock syndrome, where you have the release of toxic elements, mostly from staph. You probably know it mostly from the use of large extra absorbent tampons back in the probably 80s. Caused a lot of women with toxic shock syndrome, and it's once it sets in, you're in the ICU, and the mortality of that is quite high. Membranous or pseudomembranous colitis or inflammation is here. The reason it's called pseudomembranous is because here's the classic thing for diphtheria. If you have a grayish membrane on the tonsils or the posterior throat, it's diphtheria. The answer in the question is always diphtheria. It looks like a membrane you could peel off. A grayish membrane in the back of the throat is diphtheria. Over on the right side here, this is pseudomembranous colitis. People who take a certain antibiotic. When you take an antibiotic, and the reason taking antibiotics is not a trivial matter is because it wipes out bacteria everywhere. If you take an antibiotic for your strep throat, it's going to kill the strep, but it also kills the normal flora in your vagina and in your colon. Antibiotic-induced diarrhea is about 10% incidence. It's quite high. If you mess up the normal flora, the normal colonization of your colon, you can get an overgrowth of a bacterium called Clostridium difficile, C. diff, which produces these membrane-looking structures in your intestines. They produce a toxin that can actually kill you. So the presence of C. diff, Clostridium difficile, is something you have to recognize early in a patient presenting with diarrhea, fever, following antibiotic use, and you need to treat it, or they will die. They can die. It's quick and it's nasty. As is diphtheria. I've never seen a case of diphtheria. Anybody, international people, ever seen a diphtheria case? You seen a diphtheria case? You seen one? I've never seen one myself. I've seen pseudomembranous colitis several times, but not, or had to deal with pseudomembranous colitis a lot, but not diphtheria. Did they have the membrane? Were you able to
Yeah,
look
we
at
sent
it?
to the lab,
Yeah.
the pathophysician, the microbiologist took it, and then we saw it under the slide as well.
Most of the immunization, childhood immunization includes immunization against diphtheria. So you're not typically going to see it in school-age kids over here. You may still see it though in migrants. So you always have to be cognizant that the people immigrating to this country don't think that they can't have measles, mumps, rubella, diphtheria, smallpox, everything else, because they could be coming from America without those types of immunizations.
So if you're on an antibiotic, should you be taking like a probiotic or something with it?
That's a good question. Should you be taking a probiotic? Wouldn't hurt. Eating yogurt with active cultures, something like that. Also, when I see women in the clinic that I'm going to treat for a strep throat, I'm not going to treat you with an antibiotic for a viral throat, but a strep throat. I always ask them, when you take antibiotics, do you have a problem with yeast infections? If they say yes, and you would be surprised at how many women do, they'll take an antibiotic and they get a yeast infection. Then I give them, in addition to the amoxicillin, I'll give them a script for diflucan, which they can take if they get a yeast infection. It's quite common. And as far as women, in the yeast infections, doing things like eating yogurt with active cultures is one way to help prevent yeast infections in women. Not putting the yogurt in there, but actually eating it. I don't know why. I think it has a lot to do with, maintaining the normal pH of the vagina.
Okay, but I was,
No, we don't want to get off on the vagina thing here. No, go ahead, Taylor, go ahead.
I was actually told by my OBGYN, and I didn't do it, but that if you got like the non-flavored yogurt and actually put it on your vagina, that it could prevent like yeast infections and like all of that. I don't know. I'm serious, she actually told me that I could do that.
Don't tell me when you do.
I'm gonna put yogurt down there.
I was just waiting.
I guess while we're on the topic,
It just sounds like
you have to realize though that maintaining the normal microbial environment, the milieu of the vagina is important. And in women who take antibiotics, douche, some say fragrance scented baths, an increase in sexual activity, a decrease in sexual activity, anything that changes the internal environment of the vagina can result in a yeast infection. So, just keep that in mind.
I'll do that.
This is just ponder that later on. Hanging out at the house. You've already looked up lymphogranuloma. You've already looked up, what was the other thing? Aphthostomatitis. Now you're on to frozen yogurt. This is an example of the a discussion of the complement system. It's actually complement is essentially 30 plus proteins that are found in a whole complex of proteins. They're mostly produced by the liver and are present in the circulation. They circulate in an inactive form, and during the presence of certain receptors or chemotactic agents, they become active and produce they are a destructive force to invaders. This is an example of that little tubular thing. It's also associated with complement, as well as CD8 positive T natural killer cells that can produce those little pores in bacteria that can kill them. Or like graft versus host, if you got a kidney transplant and that you attack, this is one of the mechanisms that you attack it. You put the little pores in the renal cells to kill them. Right? It's a very brief, read over this. I'm not going to ask you a whole bunch of questions on complement, but you need to understand that it does exist. Interestingly, most of the biologics that are present now, they haven't focused on the complement system. I see that coming in the future. Most of the messing around with the immune system in treating disease has to do with immunoglobulins or tumor necrosis factor, the chemotherapy, the chemotactic agents. They haven't developed them that deal with complement yet. Chronic inflammation, if you can't clear the problem, it's going to turn into a chronic issue. I mentioned asthma earlier. Myasthenia gravis is an immune disorder where your body is attacking the neuromuscular junction, essentially. Prolonged exposure. Silicosis is an exposure to the sand dust that you're going to see in people who work in glass factories, is an example of that. Granulomatous inflammation is interesting, and what this is, I mentioned earlier, your body tries to wall off the offender, and that's what this is. When it walls it off, it produces a little nodule. That's a granuloma. And when you're talking about granulomas, there are two types. They're caseating and non-caseating. Caseating means that the middle of the granuloma, this walled off thing, is filled with dead stuff. It's not vascularized, it's dead stuff. It's a cheesy-like substance. That's why they call it caseating. I guess, where is it? Caseous. Caseous means cheese in whatever language, maybe Latin or something, I don't know. So you can see this nodule here that's been walled off. That's your granuloma. You can see it again on this side here. There's the granuloma there, surrounded by a wall of connective tissue cells. Here are different granulomatous diseases. Tuberculosis is the one that you're probably going to encounter or hear about the most. Your body, most of the time, if you get a good healthy dose of mycobacterium, your body will try to wall it off inside your lungs. And most of the time what you're going to wind up with is a caseating granuloma, a cheese, well, you'll see it in just a second. That's why you check for an x-ray. If you have a positive PPD, that's why the next step is an x-ray. You're looking for the granulomas of TB. Leprosy, yes ma'am.
Do they know why tuberculosis tends to caseate and the others don't?
I don't know why that is. One thing about tuberculosis is that the cell wall of tuberculosis or mycobacterium is different from that of regular bacteria. It is much more difficult to deal with than staph, strep, Klebsiella, anything else. I don't remember from microbiology days, it has an extra wall around it that just your average bacteria doesn't, from what I remember.
Staining it is really hard. I think they heat it or...
Yeah, there's a stain called acid-fast stain that identifies the organisms. It doesn't stain under a typical hematoxin, H&E stain. You have to do this special acid-fast. The presence of acid-fast bacilli on a stain says you have tuberculosis. Leprosy, we don't have a whole lot of leprosy in Oklahoma, but those that do have gone on mission trips. Have you ever seen leprosy? Have you seen leprosy? Yeah. It's a nasty bug to try to get rid of. There are cases of leprosy in Oklahoma. There were 2 or 3 cases, I think, last year. So it is around. Syphilis, there are many more cases of syphilis in Oklahoma. Syphilitic lesions of the nervous system produce a thing, tertiary syphilis of the central nervous system produces a granulomatous lesion, mostly of the spinal cord, called a gumma. Remember we were talking about tabes dorsalis and proprioceptors? Gumma is what the destructive lesion is that produces tabes dorsalis. Tertiary syphilis. Cat scratch disease, which is another reason they have cat scratch disease. It produces humongous, most of the time you get scratched on the hands, back of the hands, and people will come in with these humongous lymph nodes in the epitrochlear or axillary region. huge, great big lymph nodes. They are actually granulomas trying to wall off the organism. It's called Bartonella henselae is the name of the organism. It was actually identified by an Oklahoma microbiologist. What's next? Sarcoid. Sarcoid is an immune disease that produces these granulomas. They can be in the skin, but the ones that are most deleterious are those of the lungs. And I think this illustration here shows you different stages of sarcoid disease. It looks like a bunch of grapes here on either side of the mediastinum, which is the middle of the lung, middle of the chest x-ray. You see this cluster here, that cluster there. That's not normal. So as it develops into these granulomas, that's the progression of sarcoid disease. And finally, Crohn's disease can produce granulomas as well.
So the non-caseating, so they just don't have the walls around them?
Yeah, so all of these, the only caseating one in this whole list is the tuberculosis. And here's an example of a caseating granuloma there. It looks like cheese, butter, whatever you want to call it, in the center of that thing. This is a non-caseating granuloma. This is kind of cool. These sutures that weren't taken out here and here, so it goes in and out. So you get two cross sections, right? You see it made a nice nodule around it. You can tell that this is not monofilament. This is not like a fishing line. It's a braided line like silk because of all the little different things that were woven together to form the suture, right? It's like thread. If you were to take a cross-section of sewing thread, that's what it would look like. If you take a cross-section of fishing line, it's just one continuous sheet, right? Monofilament versus a braided type of thread. This thing up here is a granuloma that occurred of the piece of the tendon sheath. These things happen frequently in different places. You'll see them as ganglion cyst. Did I mention those before? Have I mentioned those before? Well, we will this week when we talk about that and talk about the wrist in anatomy. Little swellings, mostly painless swellings. They can become painful if they're pressing on something else. And you excise them. You see they have a capsule around them because you've walled it off. Manifestations of acute inflammation here. Systemic manifestations you see there. And everybody's had all of these. She's having all of them right back there on the back row right now. The WBC count, the white blood cell count, I said the predominant cell type is SEGs. This is a segmented neutrophil. You can see why it gets its name. The nucleus is segmented. This is an adult one. When you get infected, these things are produced in your bone marrow. Your bone marrow is going to say, if you have an infection, I need to produce more SEGs. So the white count will go up because you have more white blood cells circulating, trying to get to the offending issue. But what happens is the bone marrow starts spitting out immature SEGs. And so they look more like that. The nucleus has not become segmented yet. It's more of a band. So what you see in infections is an increase in the band count. Normally you have less than 4% bands in your circulation. If you get pneumonia, you might wind up with a band count of 10, 11, 20% of the white blood cells. That's called a left shift. When you have an increase in the band count, that's a left shift. It signifies a bacterial infection.
Can you show us the band on that?
Yeah, this is the band. Oh,
Which signifies what?
that's a seg. These are two bands. All of these things are red blood cells. All these other things are red blood cells. Interestingly, that little thing right there is a platelet.
Okay.
I'll show you over here because I was informed that you can't see. That little thing's a platelet. Okay, any other questions?
So more bands increase within the WBC? Where?
No, so the white blood cell count is normally, and you're going to get an entire lecture on this. The WBC count is normally, say, 4,000 per cubic millimeter. That's the total white blood cell count. So if you break it down to neutrophils or segs, lymphocytes, eosinophils, basophils, and
Monocytes.
not mast cells,
Monocytes.
monocytes. So normally you're going to have, of that 4,000, 60% will be segs, 35% will be lymphs, and then let's say 2, 2, 2.
This is
Okay?
in a healthy individual.
This is in you right now, sitting here right now. So if you have pneumonia, your total white count, so it's pneumonia, if it's bacterial pneumonia, these guys fight bacteria, right? So you're going to increase the number of these. So in, let's say, pneumonia, your WBC count may go up to 11,000. That's a pretty healthy infection. And then your segs are going to predominate, right? Because if you sample 100 white blood cells and you've increased that many of just segs, you might find your seg count now is 85%. Whereas the lymphocytes, you're only going to have 12%, and then 1, 1, 1, something like that. All right? So of these increased lymphocytes, of these increased segs, you're going to have more of them that are bands, because you're pushing them out faster. So your normal band count, which is 4%, if you were to sample all of the white blood cells, up to 4% will be segs. Up to 4% will be bands. In this active infection, your band count may increase to, say, 8% or higher. You're pushing out more immature segs to fight this infection. That's called a left shift.
That helps, thank you.
So while you're sitting on a cot this weekend, and you've gone through lymphogranuloma, you've gone through aphthostomatitis, you've gone through the non-flavored yogurt on your hoo-ha. Here's another one to consider. If you have a viral infection, the white blood cell count that predominates in viral infections are lymphocytes. So on the differential here, you might have, instead of 35% lymphocytes, you might have 60% lymphocytes. That's called a right shift. Does that make sense? It absolutely doesn't make any sense at all. One's bacterial, lymphocyte, segs. The other is viral, is lymphocytes. Who put that together? But anyway, that's what it is.
Do the lymphs have bands as well?
No. The lymphocytes don't look anything like that. You will get nauseatingly familiar with lymphocytes later on. Okay. That's the end of my discussion on inflammation. I will see you this afternoon.